to have Dr. Yousif Ahmad join us for today's grand rounds. I'll do a quick brief introduction. Dr. Ahmad earned his medical degree from the University of Nottingham in England and completed his residency at Birmingham City and Sandwell General Hospitals, followed by fellowships in cardiovascular medicine and interventional cardiology at Imperial College of London. His advanced training included a fellowship in complex and high-risk PCI and mechanical circulatory support at Columbia, and a fellowship in structural heart disease at Cedars-Sinai. Dr. Ahmad also holds a doctorate in aortic and coronary physiology from Imperial College of London. Clinically, he specializes in treating chronic total occlusions and complex PCI. And prior to joining UCSF, he served as the director of Yale University's program in complex and high-risk PCI. So we're very happy that he traveled and moved across the country to join UCSF, the better coast, as many of us, I'm sure, would agree. And today he will provide an evidence-based overview of the role of PCI in management of coronary artery disease. So without further ado, Dr. Ahmad, thank you.
Thank you. Thank you, Evan. It's really a pleasure to be here. I'm going to try and give what I'm calling an evidence-based approach to contemporary PCI. I will give a little bit about my background. I've met some, but not everybody in the few months that I've been here. I'll then get into the sort of main bulk of the talk. We'll talk about indications predominantly, but a little bit about procedural considerations. I'll try and make it both evidence-based and case-based. And I do, have a commitment that any data or evidence we show in this talk will all be from randomized controlled trials. There'll be no observational data shown at all. If there are questions as we go, I'm very happy to take them and stop, just either yell or put a hand out. Otherwise, hopefully, I'll try and finish a little early so we can have a discussion. As Evelyn said, I did all my training sort of in the UK, medical school in Nottingham, and then I did my cardiology and interventional cardiology at the Hammersmith at Imperial. And I did a PhD there, and I was there in total from 2013 to 2019. And it was a very, very exciting time to be in that particular department. And I would say for two main reasons. One was a very big drive on coronary physiology and the sort of invention of a brand new index of coronary stenosis severity. Those of you who have rotated through the cath lab have probably seen us do these measurements, what's called IFR, very frequently. And up until a few years ago, this index didn't exist. There was only really FFR, which was based on hyperemia. And my mentor sort of invented this concept and then took it from sort of concept inception to adoption in clinical practice backed by randomized controlled trials in a very, very short period of time. And so as a research fellow, that was really, really, energizing and exciting to see how something could go from sort of proof of concept to routine application. It's used in cath labs, all around the world. And I would say the other reason it was very exciting to be at Imperial at this time was a trial that I think probably everybody has heard of called the Orbiter trial. So this was, again, run out of Imperial. My mentors, Daryl Francis and Rasha Alami, sort of conceived of this trial, designed it, and then executed it all out of, our unit at the Hammersmith with a few other sites recruiting patients in the UK. This was we'll talk about it a little bit later in the talk, but, placebo-controlled randomized clinical trial of percutaneous coronary intervention versus medical therapy for stable coronary disease. And as I think everybody knows, it did not show a significant benefit of PCI over placebo for stable coronary disease. But again, having the opportunity as a research fellow to be a co-investigator and a co-author on that, see how these complex clinical trials can run was very, very, invigorating. And so then this was in 2018, 2019, I was finishing my PhD. And I thought, what is the natural next step, having just participated in this trial to show that PCI doesn't work in stable angina? I thought I'd go do a CTO fellowship at Columbia. So Columbia at the time was the biggest CTO program in the world, probably. And it was not a particular obsession with recanalizing CTOs that made me kind of seek that out. But I had benefited from doing very high volume of interventional procedures in my training. But I felt that there was a plateau or a limit in terms of the skills I had to treat the most complex patients and lesions. And I saw a kind of disturbing pattern where often the sickest patients with the most severe disease who were not candidates for bypass surgery often didn't get treatment at all and had very, very poor outcomes. And so I really was motivated to be able to gain, the skills and experience to treat the whole spectrum of coronary disease. If a patient, comes into the hospital or ends up on the cath lab table, I didn't want to have to sort of say no or turn a patient down on the grounds of not having the capabilities to treat it. So I went to Columbia. I did a year there, which was, very, very important for sort of the trajectory of my career, I would say. I then went to Cedars. I'd had a long-standing interest in structural, had done some in London, and I did what was nominally a structural fellowship. At that time, Cedars didn't have a CTO CHIP fellow, so I ended up doing a whole lot of those cases, which again was, really helped to consolidate the skills that I'd gained in New York. I then went to Yale, where I was on faculty for 3 years. I similarly had a role in structural heart and TAVR, but my main remit was to try and grow and build their coronary program. They're a very busy cath lab, high volume, good clinical volume, but maybe not a lot of focus on these most challenging cases. And so we were able to very successfully build a program. Honestly, a lot of the things that we worked hard to establish over my 2 or 3 years, they are already in place here that, Krishnan and others have put into place. And I would say that, probably the 2 ways that we were most successful in growing that program was a strong collaboration within the interventional faculty, no fear of sort of competition for cases. We would double scrub, refer to each other, and that was, a culture we really, really tried to put forward. And then also very strong collaboration with cardiac surgery. Very frequently see patients together in patient service or, in the clinic, see them jointly and sort of collaborate to figure out the best options for the patients. So I'll take you through now, what I consider, my approaches and the things I think about for PCI. On a very basic level, why do we offer any type of therapy to patients, invasive or medical or otherwise? Prognostic benefit, the most important prognostic benefit is improving a patient's survival. That's in randomized trials, that is going to be an improvement in all-cause mortality. It's not the only way we can improve prognosis. I think there are other important metrics of prognosis. We can prevent myocardial infarctions and things like that. And if we can't improve prognosis, then we have to think of whether we're going to improve patients' symptoms. And so the first take-home message is we shouldn't do anything to any patient if we're not going to make them feel better or improve their prognosis. And particularly for our interventional fellows, I think if you take that message forward as you go into practice, it's a very, very good starting point. If you're not going to modify the prognosis favorably, if you're not going to improve the symptoms, then there really isn't a role to be doing anything. So symptomatic benefit, I touched on Orbiter. I learned a lot from participating in that trial. One of the things that I learned, honestly, was just if you're doing clinical research, the importance of having a very simple, testable hypothesis. So what was the hypothesis of Orbiter? It was that PCI would increase exercise time more than a placebo procedure. That's very easy for anybody to understand. And it's also very easy to test if you design your trial appropriately. And the primary endpoint, and it's important to remember what the primary endpoint is, it's the delta in exercise time between placebo and PCI. It's not the difference from baseline to follow up with each procedure. It's the delta between the 2. And so if you look here, this is the primary endpoint in Orbiter. PCI from baseline to follow-up leads to a 28.4-second improvement in exercise time. And that is statistically significant if you look at just the PCI group from baseline to follow-up. But the placebo group also had an almost 12-second improvement in exercise time. So the delta between the 2 is 16.6 seconds, which is not statistically significant. I think there are some important, contextual aspects. Patients were very intensively treated. Rasha, who was the first author on the paper, called these patients at home herself several times a week, asked them about the symptoms, what the blood pressure was, what the heart rate was, and up-titrated their anti-anginals. And so patients were on average 3 to 4 anti-anginal drugs. Whether that is achievable in routine clinical practice in the UK or the US, we could talk about. There were some potential benefits from PCI, but this is caveated that this was not the primary endpoint. But PCI did result in more freedom from angina than placebo. But again, this is a secondary endpoint of a neutral trial. So this actually didn't appear in the Lancet paper at all. But in subsequent, some of the sub-studies we published in Circulation, there was a suggestion maybe of benefit because there was an increased chance that you're free of angina. So they designed Orbiter 2. This is kind of after I left. Some changes in the design from Orbiter 1 to Orbiter 2 were just to prevent people complaining. So people said that Orbiter 1 was too small. It wasn't. It was perfectly powered for the endpoint they had, which was exercise time, but they didn't want people to say, oh, it's too small again. So they enrolled 300 patients. They also changed the follow-up from 6 weeks to 12 weeks. Again, there is no biological reason why you would feel better after a PCI at 12 weeks if you didn't at 6 weeks. But when they published Orbiter, everyone said the follow-up was too short. So they extended it to 12 weeks. The most important change is they stopped, patients were taken off all their anti-anginal medications. Now, I want to emphasize that prognostic therapies were not stopped. Statins weren't stopped, blood pressure medicines weren't stopped. And if your anti-anginal had another role, like you're on a beta blocker for LV dysfunction, then it was continued as well. But if you were just on ranolazine or long-acting nitrates or whatever, those therapies were all stopped. And what that meant was that patients had severe angina at baseline. In Orbiter, when patients were on lots and lots of medical therapy, they didn't have as much angina at baseline. If you have less angina at baseline, it's going to be harder to show a benefit with therapy at follow-up. They reported exercise time, and I'll show you that, but they actually used a novel angina symptom score. Every patient got a smartphone and an app that they would be asked to go into, and they would record the number of episodes they had and the intensity, and that was the primary endpoint. And they allowed multi-vessel disease. Orbiter 1 was purely single vessel to try and eliminate the effect of residual ischemia. But this ended up being predominantly single vessel as well. It's very hard to do that protocol in multiple lesions. Patients need to have, IFR and FFR at baseline. You have to wait a period of time. This is all under blinding with masks and headphones, then do the PCI, then repeat it. If you have 3 lesions or 3 vessels, it's very difficult to get through all of that. But this did show significant benefit. These are the plots for the primary endpoint. And if you see here, the PCI group, much more likely to have, minimal to no angina compared to the placebo group, use of less anti-anginal medications. The CCS class was a lot less in the PCI group, and the exercise time was better. Instead of that non-significant 28-second or 16-second difference, it was now statistically significant 60-second improvement in exercise time with PCI. To be fair, that's the equivalent of taking one anti-anginal drug if you look at the anti-anginal drug trials. But all of the endpoints, favored PCI. So whether you're looking at, Seattle Angina questionnaires, exercise time, freedom from angina, the angina symptom score, they all favored PCI over placebo. So I think it's fair to say that PCI has a symptomatic benefit in patients with stable coronary disease. Anti-anginal medical therapy also has the same benefit. And so I think either approach is reasonable depending on certain things, patient factors, patient preference, and the risk of intervention. I think it's not reasonable to do a high-risk procedure when you can achieve the same with medical therapy without trying medical therapy first. I think in a very, very low-risk procedure, it might be reasonable to offer patients both options up front and let them choose. So that's symptomatic benefit, stable coronary disease. Prognostic benefit, I think the most important thing when we are looking at patients with coronary disease and trying to understand if we can favorably impact their prognosis, it's to categorize them appropriately into stable or unstable coronary disease. This is a meta-analysis we published in Circ Outcomes in 2020, and we stratified by stable and unstable coronary disease. This was just after ischemia came out. These are all the randomized controlled trials of PCI versus medical therapy or invasive therapy versus medical therapy. And there's no difference whatsoever in all-cause death. The point estimate is 0.98. You can't get more neutral than that. Similar for cardiovascular mortality, the point estimate is 0.88. It's not statistically significant. And the same for myocardial infarction. Regrettably, some previous meta-analyses of what were claimed to be stable coronary disease would lump in some of these other patients. So they would take patients that had an unrevascularized MI, that had angina afterwards, and they would say that this was stable coronary disease. They would mix those trials with the stable CAD trials, and they'd say, oh, look, there's a reduction in death or death in MI. Or patients who had multi-vessel disease after a revascularized STEMI. And if you lump those patients in with the stable coronary disease patients, you might see a benefit, but it's just not fair or accurate or correct to do that. But if you look at these subgroups of unstable coronary disease, NSTEMIs, multi-vessel disease after STEMI, unrevascularized MI, there are benefits. There are improvements in all-cause mortality, there are improvements in cardiovascular mortality, and there are improvements in myocardial infarction. And this is all from randomized controlled trials only, no observational trials at all. And so I'd say my third take-home message is there is no evidence of a favorable effect of PCI on hard outcomes for patients with stable coronary disease. We have to categorize those patients appropriately. Once you've had an acute coronary syndrome, you kind of have fallen out of that bucket of stable coronary disease. But if you're just, a patient who's walking around with angina and has coronary disease, that's truly stable. We are not going to improve their prognosis. So
you're saying anybody who's an ACS, even if it's not the vessel that stable, they're no longer.
Exactly. So I don't know why it is. There's something about these patients' biology once they have an acute coronary syndrome. If, let's say, a patient has an ACS, you treat the culprit and they have a bunch of residual lesions. That patient now is not in the stable coronary disease bucket because we've done many, many randomized trials post-MI multivessel disease, and those patients benefit from more revascularization. So I think it's really important we make that distinction. If they're truly stable, it's a symptom-guided therapy. If they've had an event, an ACS, an MI, then they are unstable and there may be a prognostic benefit. So I think that we can't extend those prognostic benefits that we see for ACS into the stable coronary disease patients, but equally, we shouldn't conflate the lack of, prognostic benefit in stable CAD for those who've had an ACS. There is a prognostic benefit in NSTEMI, multivessel disease after STEMI, unrevascularized MI with angina. Those patients get prognostic benefit from PCI. So then to Sam's point, how much, if we know that it benefits to get to revascularize in ACS, what do we do with these patients with residual lesions and multivessel disease? This is something we tried to answer in this network meta-analysis we published in JACC this year. This has 16 trials and about 12,000 patients, I think, and it has both NSTEMI and STEMI. And if you look at all of these outcomes, if you compare complete revascularization to culprit, there are significant benefits to complete revascularization. In these trials, that's all with PCI. There's no bypass surgery in these trials. And you improve all of these outcomes, including all-cause death, which is statistically significant, which had not been shown before. We tried to dig in as best we could to understand, is it better if you do the complete revascularization immediately or staged? If you do, with network meta-analytical techniques, you can get indirect evidence and try and understand it. The truth is we can't tell conclusively. These are p-scores, the higher to 1, the more likely it is that's the best strategy. But what is clear from our analysis, for every endpoint, the worst strategy by far is culprit-only revascularization. We need more head-to-head trials to understand if we should do immediate, complete, or staged, but culprit-only revascularization, excluding cardiogenic shock, all these trials excluded cardiogenic shock, is clearly the worst strategy. Same for using physiology or angiography. Some of the endpoints, it looks like maybe physiology is better. But again, this is caveated. There's a lot of indirect evidence, which means these aren't head-to-head trials necessarily. It might be physiology-guided versus culprit, angiography-guided versus culprit, and then you use that to try and get indirect evidence. But again, it's very clear that the worst strategy for these patients is culprit-only revascularization. So my fourth take-home message for you is that in patients with ACS, more complete revascularization is associated with better outcomes, including all-cause mortality. And the symptom status of the patients is not so important here. None of these trials included symptomatic status as an inclusion. None of them included non-invasive stress testing. They all included either angiography or intracoronary physiology to guide. And bypass surgery hasn't yet been tested in this setting. There are ongoing trials for that. I think if the anatomy is clearly favorable for bypass surgery, it's reasonable to consider. You then have the issue of patients who are on DAPT, when they're culprit, et cetera. But it's not yet an approach that's supported by randomized data. So left main coronary disease, we often think of as prognostic. The reason we think of it as prognostic is from these historical trials comparing bypass surgery to medical therapy. We have now multiple randomized trials that have compared PCI to bypass surgery. This is a meta-analysis we published in European Heart Journal in 2020, just after Excel came out, and there was a lot of controversy about Excel and MI definitions. But if we looked at all of the available randomized data, there was no significant difference for all-cause death between PCI and bypass surgery for patients with left main disease. Clearly a benefit to bypass surgery for durability of less procedures, no doubt about that. If you have bypass, you're less likely to need repeat revascularization. This was then corroborated in an individual patient level meta-analysis that was published in the Lancet. 5-year all-cause death, no significant difference, hazard ratio is 1.10, and 10 years the same. The sort of elephant in the room, or the criticism of that, is there is not an arm in those trials where patients are treated medically. I think that's a reasonable claim to make, but if you want to treat patients with left main disease medically, you have to do that trial. That is not an approach that's supported by randomized data at the moment. So patients with significant left main disease, no difference in survival between CABG and PCI at 5 to 10 years. Medical therapy alone is not an approach supported by randomized data. I think that would be a very reasonable trial to do now. Another group that we think of as, very relevant for sort of event reduction or prognostic benefit is these ischemic heart failure patients. I think everybody is familiar with the STITCH trial. The first Kaplan-Meier plot is from the INDEX 5-year follow-up in the New England Journal of Medicine. All-cause death, hazard ratio is 0.86. The upper 95% confidence interval is 1.04, so no statistical benefit. But at 10-year follow-up, in STITCHES or the STITCH extension study, you can see the hazard ratio is very similar. It's 0.84, but there's so much more follow-up. There's increased accrual of events. There's more precision around the point estimate, and now it's statistically significant. The other reason why the benefit does not appear at 5-year follow-up is if you look at up to 2 years, the curves are in the opposite order, because bypass surgery is, a morbid condition or morbid surgery. The overall number of deaths is greater with bypass than medical therapy up to 2 years. And at 30 days, there's 3 times as many deaths with bypass surgery. But then if you survive, you get the benefit of bypass surgery. So once you follow patients to 10 years instead of 5, you allow that benefit to emerge, clearly a benefit with reduction of all-cause mortality. People then, wondered, should, PCI does not have the same upfront risk and hazard, should we treat these patients with PCI? And the reason people think that is, despite the STITCH data, patients with ischemic heart failure hardly ever get bypass surgery. One analysis from Jack, US-based, showed that 1.3% of patients who are hospitalized with heart failure get CABG within 90 days. And there's other data that shows if you present with acute heart failure, you're actually in one of the groups least likely to get bypass surgery. And again, by definition, everyone in STITCH was a good candidate for bypass surgery. All the patients enrolled were willing to have it. Maybe that's not the case in the real world. People are worried about the early hazard of bypass surgery, especially for patients with poor ventricular function. In STITCH, the benefit of CABG diminishes with advancing age. If you need to live 10 years to see the benefit, in older patients, is it as relevant? And some patients just can't have surgery or don't want to have surgery. I would say this is kind of what over time, and maybe still now to some extent, happens. The natural kind of process for these patients is they get diagnosed with heart failure, they get an angiogram, it shows severe multivessel disease, they get evaluated for surgery, they're not candidates, then they get an automatic trigger referral for PCI. And I think that the new data really suggests that this should not be an automatic trigger, and we need to change some of these, I think, natural rhythms and patterns of treating these patients. This is the REVIVE trial. I'm sure, again, you're all familiar with it. The primary endpoint, all-cause death or heart failure hospitalization, there's really no difference between the two arms. And this does not look like the STITCH 5-year plot that is starting to separate, that if you follow them to 10 years, the benefit will accrue. The hazard ratio is 0.99. We'll see what happens with longer term follow-up, but there's no suggestion of a prognostic benefit to PCI with these patients. ACS was excluded. I think it's important to say that. And the vast majority of patients in REVIVE are actually mildly symptomatic or asymptomatic. So almost no patients had significant angina. And even if you look at NYHA class, the vast majority, 3/4 of the patients were in NYHA class 1 or 2. There was less on-plan revascularization in the PCI arm. There was a benefit with KCCQ score that got attenuated with longer-term follow-up. There was less spontaneous MI with PCI, but obviously more peri-procedural MI with only one arm getting a procedure. I wouldn't say that PCI is completely off the table for patients with ischemic heart failure. I'm just trying to say that I think we need to be more thoughtful than automatically doing it for everyone who gets turned down for bypass. I'd offer it to patients who had an acute coronary syndrome and patients who have, refractory angina. I think those are 2 clear indications. I might think about it with younger patients, but I will see these patients and be honest with them about the data that we have in terms of, what the benefit might be. And you have to look at the comorbidities in the coronary anatomy. A lot of these patients with advanced ventricular function have bad vascular disease and bad kidneys and bad hemodynamics and calcified coronaries. And I think the risk-benefit calculus, has to be very, very carefully weighed for these patients. It needs a true multidisciplinary assessment. These patients hopefully will get referred from our colleagues in advanced heart failure who, have both optimized them medically and then thought about other therapies, bailout plans if PCI doesn't go well. These things all really need to be thought about, planned in advance, and discussed with the patients. In the absence of ACS, there really isn't a rush. I think that's one of the main things that Revived shows us. These patients, outcomes don't appear to be clearly modified by PCI. We have more than enough time to treat them medically, optimize them, see their clinical course in the outpatient clinic. If they have refractory symptoms at that point, I think, it's a different discussion, but I think there's no rush to revascularize these patients. And so my next take-home message is that PCI does not improve prognosis in asymptomatic stable patients with ischemic systolic heart failure. And it should only really be offered judiciously in select scenarios and after a very candid discussion, including the available trial data. So the question is, would we offer it to improve their ejection fraction because their ejection fraction hasn't improved with medical therapy? The truth is there is no randomized data to support that as an approach. And so I think it is, not that I'm trying to say PCI is terrible, but I think it's disingenuous of us to offer PCI with a realistic expectation of improving ventricular function. I think outside of, a clear-cut ACS, that, this is an acute drop in EF that, you would reasonably expect. I think patients that look like the Revived patients that are on GDMT with stable NYHA, let's say class 2 symptoms, CCS class 1, I don't think it's reasonable to offer PCI to improve the EF.
Mentioned earlier, this definition of what's an ACE. Sounds like anyone who's had it. So what if this ischemic heart failure patient can be classified as an ACE?
So I think if a patient has had an infarct and has post-infarct, so the question is, we talked previously about patients who've had acute events, acute coronary syndromes or infarctions, benefiting from revascularization. And how do these sort of ischemic heart failure patients fit in? I would say we have 3 clearly categorizable group of patients who benefit. Those are ones who had an MI that wasn't revascularized and had post-MI angina. There are maybe half a dozen trials there that show benefit. There are patients that have had a revascularized STEMI and residual disease, and there are maybe 15 trials there that show benefit. And then there are NSTEMI trials that show benefit. I think if the patient doesn't fit into any of those buckets, let's say they've had an infarct, which has left them with poor ventricular function, and they don't have post-infarct angina, then I'd say they're more like a Revived patient than those. And I would not offer PCI with an expectation of modifying their prognosis. And so those are all, indications. I now want to very briefly talk about, some data. As I said, I'm trying to keep this as evidence-based as possible about optimizing outcomes of PCI. And this was a meta-analysis we published in the Lancet this year. And we looked at all the intravascular imaging randomized control trials, whether it's OCT, whether it's IVUS. Again, we took this network meta-analysis approach where we could include trials that compared OCT versus IVUS or either alone versus angiography. For these, this is just direct evidence. So this is not from the network. This is just trials head-to-head, intravascular imaging versus angiography to guide PCI in various clinical settings, some stable, some acute, some complex, some straightforward. But the relative risk for all-cause death is 0.75, and it's statistically significant. If you look at all of these endpoints, the primary endpoint was target lesion failure. Very large statistically significant benefit. The components of target lesion failure, cardiac death, target vessel MI, ischemia-driven revascularization are all improved. 50% reduction in stent thrombosis. As I said, 25% reduction in all-cause death, 18% reduction in MI, and 29% reduction in repeat revascularization. All statistically significant, all from randomized control trials only. And so what I want particularly our interventional fellows, but really everybody to take away is that the use of intravascular imaging is one of the only things we have that improves both the safety and efficacy of PCI, reduces stent thrombosis, terrible safety event, reduces repeat revascularization, but it also reduces all-cause death. Its use in PCI, in my opinion, should be mandatory, and it should be class 1 in the guidelines for every form of PCI. European guidelines have just updated to make it class 1 for sort of left main and some complex lesions. To put it in context, the data for intravascular imaging is way stronger than the data for drug-eluting stents ever was compared to bare metal stents. Drug-eluting stents have no impact on MI, death, cardiac death, and none of us would dream of putting a bare metal stent in, and drug-eluting stents are class 1 in all the guidelines. So hopefully with this new and this now accumulation of data, the guidelines will soon change to have it as class 1 for everything. All right, so I'll show a couple of cases. Again, stop me please if there are questions. I'll have like some very brief concluding thoughts, and then we will any other questions and discussion I'm happy to take. These are patients that I've treated not at UCSF because I haven't figured out the best way to sort of import the videos yet, but this is a 55-year-old male critical care physician, diabetes and some non-alcoholic liver disease. He's had prior stenting and he gets admitted with unstable angina to another facility in December of 2020. You can see he has a stent in the LAD and this kind of moderate diffuse distal LAD disease. And it was overlapped there, but I think I'll point it here. There's a very tight ostial LAD lesion just there. He's got a patent stent in the circumflex. He's got some stents in distal branches of the right coronaries. And he gets referred, I think, reasonably for bypass surgery at this time, tight ostial LAD prior stenting. He gets a Lima to LAD performed. He has some issues after surgery, but the most disappointing thing is he continues to have pretty debilitating angina. And he gets another invasive angiogram. This is his Lima to LAD, shows a clear insertional stenosis, but also the graft inserts into significant disease, both in the retrograde and antegrade portions of the LAD. And his native left main is now completely occluded. Even with an aortogram with a pigtail catheter, you can't see anything in the native left main, and they tried to engage and were not able to. And at this point, he gets a PCI to his Lima LAD insertion. Again, like a public service announcement, particularly in younger patients, stenting of the anastomosis of bypass grafts is very problematic because it really makes it difficult for you to open the native in the future. In older patients, I think it's reasonable. Balloon angioplasty is very reasonable because you're not leaving any metal there. But in younger patients, particularly ones that have shown themselves to have need frequent procedures, you really want to preserve as many options as possible. And this makes life a lot more difficult if patients come back. And he unfortunately does come back. He gets that stent, which, I guess would perfuse his very apical portion, but he has ongoing very bad angina. Remember, they couldn't engage the left main whatsoever. He gets a grossly abnormal stress test with a decline in his ejection fraction and kind of self-refers out for consideration of other options. Brought him to the cath lab. I also tried briefly to engage the left main, which I couldn't. And so I did something that we don't very frequently do, which is go retrograde through the Lima. This is challenging because both there's a 180-degree bend and then there's stent and then there's severe disease. This is an angled microcatheter, which is taking that turn. We're then able to wire up through the LED and put a wire out into the aorta. We can then snare that wire with a new guide catheter, and we now have, that's our snaring it, we now have control antegrade of the left main by being able to snare in that guide. We then stent the proximal LAD. This is just wiring the circumflex to secure that direction, and are then able to stent both and then restore his native left main circulation. He gets discharged the following morning and he was free of angina from my last contact with him. This is another case example of, just in terms of approach to cases and not rushing to do things. 57-year-old male, vascular risk factors. He's had low-level angina for many years. He's had her RCA CTO diagnosed about 10 years ago, or maybe 8 when I was meeting him. He had inferior ischemia on stress testing, was treated with 2 anti-anginals and was kind of doing okay, but low level of angina. For whatever reason, he gets admitted with worsening angina, negative biomarkers, normal ejection fraction. His angiogram is unchanged. We see this not infrequently. Patients that have chronic total occlusions, at some point, their symptoms worsen, which, their coronary anatomy doesn't change, whether it's something to do with perfusion pressure, something to do with their collaterals. I actually met him when I was on inpatient service, and my colleague who did the cath called me and said, okay, why don't you just set him up and do it tomorrow? He has this RCA CTO, but I want to impress on people that that's not the right thing to do. Almost never do ad hoc CTO PCI, and CTO PCI is a symptomatic procedure. And as I said at the start, the risk of your intervention has to weigh in to how elevated PCI is in your algorithm. If it's a straightforward case, I think it's reasonable to offer PCI earlier. Patients don't have to be on 4 anti-anginals and dying of angina for you to stent a focal lesion. But I think, calcified lesions, high-risk procedures, I think it's really, warranted to try harder. So I upped his doses of 2 meds, added a third, saw him in clinic, and he still had angina when climbing stairs and taking out the trash. It also gives you time, it's much easier to have these conversations in the office than in hospital, and patients are kind of lying there. And, I think to have informed consent, it's much easier to do in the outpatient clinic, and it really is my preference. Again, this was a case with dual injections. There's a mid-vessel CTO that we were not able to get antegrade. And so we came retrograde through septal collaterals from the LAD, which is very safe. These septal collaterals course in the septum. If you do get issues with bleeding, they tend to bleed into the septum, not the epicardium, so very unlikely to get tamponade. We then, wired, externalized. It's a calcified lesion. We had to perform atherectomy, and then we're able to get a very nice result. But the reason I show that case really is just in terms of the cadence for how to manage these patients. And then this is the last case I'll show. Is a 55-year-old male, prior bypass surgery, very bad ventricular function. He has an NSTEMI at another institution. He has CTOs of all native coronaries. He's got what look like chronic occlusions of his circ and RCA graft. He has a saphenous vein to the LAD, which had an acute thrombotic lesion, which was not intervened on. He was referred to Yale for transplant assessment. Again, I would say reasonably, but his predominant symptom was angina. And so then we were asked to take a look. This is his LAD. You can see totaled here. Circumflex is also a CTO. Those, again, both of those have occluded grafts. Right is a CTO, and then I'll show you the saphenous vein graft, which is full of thrombus, and intervening on that is extraordinarily high risk. So again, after informed consent, met him as an outpatient. We brought him in for an impeller-assisted PCI. We did the LAD first. We're able to get that antegrade, restore flow to the LAD, let him go home, bring him back, and then second procedure with the LAD open is without mechanical support. Right coronary CTO, which again, we're not able to get antegrade, but the LAD is now stented with open septals, and so we're able to come retrograde and then open his right coronary up for him. And this is a note from him from, I think, our transplant coordinator. Spoke to Mr. Blank. He reports drastic improvement in symptom profile after staged interventions, reviewed decline for listing from heart transplant waitlist due to improvement with alternative treatment modalities. He verbalized understanding. So I think we can really improve a lot of patients' prognosis and symptomatic status with PCI when we're thoughtful with where we apply it. Huh? I did this not long before I left, so honestly, I don't know. I can find out for you the feedback. So I'm going to do some very quick fire concluding thoughts, and then hopefully have time for questions still. So complexity and risk, I think these are two concepts that get modeled up a lot. A lot of these fellowships, like the one I did, is called a CHIP fellowship. It stands for Complex High-Risk Indicated Procedures. I actually don't really like the phrase complex PCI. It's a little bit vague, and honestly, patients don't care if their disease is complex or not. If it's complex, it means it's harder for us to treat. It's not a patient's fault that their anatomy is calcified or they have CTOs. And I think the goal for interventional cardiologists is to get the skills that complexity alone is not a barrier to offering treatment. And so I think we have to disentangle complexity and risk. I think risk is way more important, and I take that very, very seriously. And if the intervention is risky, that really needs a lot of thought and discussion with the patient and discussion with their family, and make sure it's appropriate for them. Complexity alone in a lower risk setting is not that, not an important consideration. They track each other. A lot of the things that are complex to do are also risky, but they're not the same thing. And so I do think it's important that we try and disentangle those when we're thinking about these patients. A few kind of like, I would say, misconceptions about people that do these types of procedures. One is that, you must hate bypass surgery and you never want patients to have surgery. I think surgery is an excellent treatment for a large number of patients. We very frequently advocate for patients to get surgery. Most of the cases that we do, Christian and I, are either ineligible for bypass surgery or they've had it in the past and redos are very, very problematic. We get a lot of our patients referred directly from surgery and vice versa. We meet the patients, we try and get them to the right therapy. And I think what is excellent here is this multidisciplinary approach. Not most places I've worked, particularly in the US, I say, don't have a formalized heart team for coronary things. We have them for valves. I think it's great that we have it here. We bring our cases, surgeons bring their cases, primary cardiologists bring their cases, and everybody discusses and nobody has any sort of kind of pull one way or another. We just try and get the patients to the right treatment. I would say another misconception is people will look at angiograms, they'll be like, all right, you guys probably don't want to get involved in this. There's way too much disease. And I think in the modern era, it's not as much of a consideration. More or less anything can be done with PCI. Definitely doesn't mean that anything should be done, but there isn't a disease pattern that's just too bad to be done the majority of the time. There are some exceptions. Very diffuse distal disease that is unfortunately bad for bypass surgery is also bad for us because you don't get good runoff. But in general, I don't think in the contemporary era, a lot of disease or, what is termed complex disease is a reason that patients shouldn't be offered intervention. This is one that comes up all the time, which is the CTO is well collateralized, so it doesn't need anything to be done. We actually think about it completely the opposite. If there was a CTO that had no collaterals, I would not be interested in opening it. But in terms of the collaterals, it's been extensively studied with physiological studies that collateral flow is not equivalent to native antegrade flow. For some patients, collateral flow is perfectly adequate. If you're 85 and you don't walk around, you don't get symptoms, that's fine. But it's been studied with coronary flow and coronary pressure. You don't get the same flow by collaterals as you do from natives. All CTOs are ischemic by definition. I don't think that should be, controversial because they're occluded, but it's also been studied that after crossing the CTO and you put a pressure wire down, the collaterals will still be there, and all CTOs are ischemic by FFR, without exclusion, even in the presence of collaterals. Good collateralization actually makes me more optimistic that what we're treating is viable. If I see the distal vessel is large and fills from somewhere, I'm a little bit more enthusiastic about doing it. Mark, your patient had a large distal LAD that I felt, better about trying to recanalize because it filled so well and was large. It wasn't underfilled and diffuse and thready. And honestly, if there's an occluded artery that doesn't fill from anywhere, no collateral source, it's probably not viable. And that would be a big disincentive for us to pursue revascularization. CTO PCI is not successful very often. I think that has maybe been a historical attitude, not unreasonably. If you look at national data, it's seldom performed. If it is performed nationally, the success rate's of 50%. I would not have a procedure. If the success rate was a coin flip or better, I wouldn't have my family member have it. But all of the, data suggests that in expert centers with expert programs that focus on it, your success rate's around 80 to 90%. And I think that's what it's been here. And where I was before, our success rates were there, and all of the recent studies suggest that. So I don't think it's fair to say that it's rarely successful. I think it's fair to say that it's not guaranteed it's successful. And again, we tell patients that, make them very, very aware. And I give them a scale, some we're 95% sure. Sometimes you're wrong when you're 95% sure. If it's a worse looking case, I think we'll say 70 to 80%. CTO PCI is definitely more risky than non-CTO PCI. No way around that. You have to be honest about that. There are things you can do to mitigate the risk, but you can't eliminate it. So again, informed consent is very, very important. You have to be honest. I tell all of the patients about the risk explicitly and in detail. I try and insist they bring a family member to clinic appointments, so you're not just speaking to the patient, you're speaking to a family member. But the procedure has become safer. We avoid higher risk epicardial collaterals. 10 years ago, they were doing them very frequently. I would say 10 years ago, the field was focused on improving success rates at the jeopardy of safety. And then all CTO operators are now more mindful of safety. We do more stage procedures. We do as much as we can to make it safer. And we didn't have, fortunately, in the 3 years that I was there, a single procedural death or need for emergent surgery. These things will happen, if you do enough cases, but I'm just trying to impress on people that it's not that, you're going to have a tamponade in 10% of cases. That's just not the case in contemporary, CTO PCI. I would say that the coronary program here, the team and infrastructure are already in place. As I said at the start, a lot of the things I work to try and build at Yale, Christian has already done here. He has been an outstanding partner and really welcomed me, and I can't thank him enough for that. I think our focus, as a coronary program is now to try and expand and outreach within the UCSF system and beyond. We are developing new therapies and services all the time. Anna Bayer and Christian both have an interest in comprehensive physiological evaluation of these patients with possible Minoka. They now have the CoraFlow system. They can test them for microvascular dysfunction and test them for vasospasm. We're discussing trying to establish a coronary brachytherapy program, and we're trying to bring in more clinical trials, some of which will bring us new therapies. The coronary sinus reducer is a promising new therapy for patients with refractory angina, and compared to CTO PCI, it's a very safe, quick, easy, 30-minute jugular procedure. In conclusion, I would say the totality of randomized data shows benefit for PCI, both reducing symptoms in those patients that we categorize as stable CAD and improving prognosis for patients with unstable CAD. With evolutions in technology and procedural techniques, I think we're now able to successfully and importantly, safely treat the entire spectrum of coronary disease. And it's just, we have to, I say, more than the technical aspect, focus on the latter, which is appropriately selected patients and the correct indications. Thank you very much.